I want to see the bone. If he or she wants you to see it, they will give it to you. Otherwise, they will skip it. So you know, satisfaction of search is the key in trauma cases. So this is a repetition of the headings. Satisfaction of search is you will pass or fail on the film because the findings usually will be subtle. So these are my concept of levels. We have done it in the past. I don't have time to go through them once again, but I will just recap the salient features in this as we proceed. Basal cisterns are critical, and similarly, the CSF spaces up in the vertex are critical. So important basal cisterns are around the midbrain, prepontine cistern, cerebropontine angle cistern, interpedunclar cistern, ambient cistern, quadrigeminal cistern, suprasellar cistern. These are critical in the trauma world, and I will tell you why. Similarly, sulci are critical, and you have to go till the vertex and see it again and again. I'm just recapping it. I'm not going to teach you all of these because you know it. Now, this is area of interest. This is the pons. This is the cerebropontine cistern, and this is the basilar artery. This is the key level where the midbrain is. Interpeduncular cistern, where I am pointing out. You will get cases in the examination where subarachnoid hemorrhage will be just sitting here and nowhere else. Similarly, around this cistern, a lot of concepts will be checked. Just a recap, this is the ambient cistern, and this is the quadrigeminal cistern. So around the midbrain, interpeduncular cistern, ambient cistern, and the quadrigeminal cistern. Anterior to that is this star-shaped cistern, which is the suprasellar cistern. Now, this portion of the temporal lobe is the uncus. Uncus is the medial most portion of the temporal lobe. And this anatomy will be checked, the concepts will be checked, particularly vis-a-vis cases of, let's say, transtentorial herniation, etc. Please remember that the posterior cerebral artery passes here, and if there is descending transtentorial herniation, there can be compression of it and there can be infarctions. So this area is particularly important. Another thing which has been asked in the examination at times, just a recap, if you see, this is the lateral ventricle. This thing is the atrium of the lateral ventricle. So the atrium is in a craniocaudal direction. It is quite a substantial structure. If the slice passes through this portion of atrium, will be posterior to the body of the lateral ventricle. If I show you here, so this is it, and portion here is atrium. This is the body of the lateral ventricle. On the other hand, here, as it passes here, which is this level, or just one second, or this level here, then the occipital horn, this is the occipital horn. Occipital horn is posterior to that. Please remember, usually, particularly in young patients, you don't see the occipital horn because it is, compressed. But at times, when it is full of blood, you might see it like this. And this has been asked in the exam, and at times people confuse it. And they say that there is intraparenchymal hemorrhage. So just wanted to show you that occipital horn can be there, and there can be blood in the occipital horn. Three different cases. Look here, the blood is going into the occipital horn. Here again in the occipital horn. Here we are at the level of the body of the lateral ventricle, and there is a fluid level. Here we are at the level of the atrium, but we are at a superior level. The slice is going like this. Here, the slice is going like this. All of these things we know. Now, this is the key concept of head injury. And you have to really concentrate on this slide. Primary effects, secondary effects, and delayed effects. So the primary effects are at the time of the impact. And here you can get two types of injuries to the brain parenchyma. One of them is contusion, and second one is diffuse axonal injury. You can get various kinds of hemorrhages, which include extradural hemorrhage, subdural hemorrhage, and subarachnoid hemorrhage. And you can get fractures. So these are all primary effects. What are the secondary effects? Now, secondary effects is that patient can get then cerebral edema, and whenever there will be edema, there can be secondary ischemia because of compression of the vessels. We'll come back to, and this concept is asked in the examination. There can be then herniations, and the most common herniations which you will see are subfalcine herniation and transtentorial herniation. And then you can get other vascular complications like dissections, etc. We have already covered these, so I'm not going to revisit them. Then there are delayed effects. Delayed effects like cerebromalacia, as in atrophy, CSF leak, atriovenous fistulas, pseudoaneurysms, leptomeningeal cyst, or the growing fractures. Some of these we have done. In today's session, we are going to concentrate on all of these and a bit of the concept of cerebral edema and herniation. So this is where we are going to concentrate on. So please remember that bleed, congealed bleed in the brain has got a density which is anywhere between 56 to 76, or at times slightly more than that. So it is 56 or more than that. Each day, the density decreases by about 1.5 Hounsfield unit. And this is an example where there is cerebral hemorrhage here. And the density on day 1 is 65. And on day 16, it is 45. And if you see here, now the hematoma is isodense to the parenchyma. Right. Candidate 1, can you tackle this case?
Yes, so this is a plain axial CT head slice showing an area in the right parietotemporal region, showing increased density centrally, which is linear, with some associated edema, mass effect, pushing the right lateral ventricle, the left lateral ventricle to the right, and midline shift to the right as well. Within the subdural space at the back, I believe that straight line is an artifact rather than, yeah.
Correct.
So at the moment, it's a partially visualized lesion on a single slice. It could be an intraparenchymal hemorrhage, could be a space-occupying lesion, but it is having a massive effect and causing sulcal and ventricular effacement.
So there is history of trauma. This is a RTA, high speed.
Oh, sorry. Yeah. So, okay. So history of trauma. Sorry. Yeah. We're tackling trauma today. So, yeah. So so it looks like a intraparenchymal hemorrhage, could also be contusions, which have had hemorrhagic transformation. I would like to, assess the brain fully to see if there are any other areas of the complete extent of this injury. But at the moment, I am concerned, given the significant edema and mass effect associated with it, And things I would assess for is hydrocephalus, any tentorial herniation, any cerebellar herniation, if it's having, significant other features of mass effect. And this is something that you let the neurosurgeons know urgently about for further management.
You've used two words. You use, it can be intraparenchymal hemorrhage, it can be, if I'm not wrong, you also use the word contusion, correct?
Yes, I said hemorrhagic contusion is also a possibility, yeah.
So I'm just having a debate on the terms which we used initially. Remind me, what words did you use to describe this lesion? Remind me, whatever you said.
So I said that there were linear hyperdensities seen in the right hemisphere with surrounding edema and mass effect with effacement of the ventricles and a midline shift to the left. And I think I said that these could represent hemorrhagic transformation of contusions, or it could just be a large intraparenchymal bleed that I can't see on one slice. I'd have to look at the whole thing.
So are you expecting intraparenchymal bleed? I'm just debating the terminologies, and you should have a very clear-cut concept. So I'm debating the terminology in the context of trauma.
I mean, I think this is a hemorrhagic contusion, given the history of trauma. Those are the most likely cause.
Okay, so let me take over. You see, the point is, what does this slide tell you? Now, this concept you have to remember. When there is acute trauma, there are two types of parenchymal injuries which can be seen. One is contusion, and second one is diffuse axonal injury. Give you an example of contusion is just like a bruise. Now, the bruise, for example, you are playing cricket and you are hit on the elbow by the ball, you'll get a bruise there. Where will you get the bruise? The bruise will be on surface. And of course, it can be very deep. So, you know, if you do an MR, there might be edema in the underlying muscle also. Now, the point is, similar is the mechanism in brain injury, contusion. By definition, the surface or the skin of the brain hits something. What is the skin? Skin is the gyri, the cortex. It hits something, and you know, the concept is that it will hit the base of skull and other places which we are going to cover shortly. And when it hits it, there will be edema. The edema will be low density. And then there is a concept of hemorrhagic contusion in which there will be, hemorrhagic foci. So in the context of trauma, the correct terminology to be used is hemorrhagic contusion. Don't use the word intraparenchymal hemorrhage. You don't see intraparenchymal hemorrhage. There is no concept of getting an intraparenchymal hemorrhage in acute trauma. So that was my point. Second thing is that, of course, there is a bit of midline shift. There is a bit of subfalcine herniation. When we will cover the subfalcine herniation, you will see that there is compression at the foramen of Monro. Ipsilateral ventricles are compressed, contralateral are dilated. We'll come back to this. Of course, you are handicapped because of only one sequence given there. Now, what is the terminology? The terminology is that brain surface injuries involving gray matter, contiguous subcortical white matter. This is the key concept. The surface has to be involved, and with that, white matter is involved. So if you go here, this thing must be involved, and then everything else is involved. So this is the key concept. Cerebral contusions can be a coup injury, which is at the site of trauma, and it can be a counter coup injury. Counter coup is on the other side. So for example, this is the site of impact. So here we will call it coup, and counter coup is that the brain will struck here. So that is, and at times the counter coup injury is more severe. This concept you have to remember that they can be, the brain parenchyma gets a contusion where it hits bony protuberances or dural folds. Common sites are antero-inferior frontal lobes, antero-inferior temporal lobes. So these are the most common sites. And in chronic cases, there can be encephalomalacia, etc., long term. Coming back, please remember the concept that any brain injury can expand. So contusions, 75% of them can expand, but anything can expand. Extradural hematoma. So let me give you the clinical context. You are the on-call radiologist, and you have picked up an subdural hematoma at 2 a.m. And at 4 a.m., you get another call by the clinicians. They say that the patient has deteriorated. We were managing the patient conservatively, and the patient has deteriorated. We want to do another CT scan. So you have to do the CT scan. You should not debate that we just did it 2 hours ago. There is a concept of expanding injuries. Anything can expand. Contusion, subdural, diffuse axonal injury, edema, extradural. So whenever clinically required, you have to re-scan. Please remember that. Now, look at this picture. In this picture, what does it tell you? As I was telling you, the surface of the brain must be involved, and then it can go deep. So this is classical contusion. Look at these sites. The red ones are the common sites. You see, this is the inferior view of the temporal lobe, the subfrontal, around the sylvian fissure. And otherwise, the green ones, for example, even the corpus callosum can have a contusion. So interestingly, corpus callosum can have a diffuse axonal injury also. But that is usually, classical site is slightly more posterior, which is splenium. But this can struck the dura. So please remember, wherever the brain will strike either the bone or the dura, there can be contusions. So, few examples from StatDX. Contusion here, contusion subfrontal associated with a bit of subarachnoid hemorrhage. So in the exam, look for multiple findings. Sometimes they will show you cases in which there will be multiple findings. So don't just stop here on one finding. Please remember that subarachnoid hemorrhage, subdural hemorrhage, contusion, diffuse axonal injury, all of them can be seen in a single case. So keep looking for them. Another case where there are hemorrhagic contusions and there is subarachnoid hemorrhage. Please remember that the most common cause of subarachnoid hemorrhage is what we call traumatic subarachnoid hemorrhage. This is the most common cause. So keep looking for it. This is a corpus callosum contusion. Usually, we talk about diffuse axonal injury vis-a-vis corpus callosum. But contusions can also happen usually here at the body. If I go back and show you that diagram once again, look here, green area. Diffuse axonal injury usually this area. And contusion will be bigger. You can well imagine this has struck the fox. Now, this is a gradient echo T2 star sequence, and this is a SWI sequence. Please remember that SWI sequence is more sensitive in picking up hemorrhages, and it is also more sensitive in picking up diffuse axonal injuries. We will revisit this. Yes, please. Over to you, candidate 1.
So these are plain axial CT head slices. And you can see starting from the top left-hand corner that and the inferior aspects of the frontal lobes bilaterally and the left temporal lobe in the top left image, there are hemorrhagic contusions. Going across, you can see that there's actually bilateral extension of these hemorrhagic contusions into the bilateral frontal lobes with significant associated edema. And there is along the tentorial leaf some high density as well, which may represent a subdural bleed, but I would like to assess those in reformatted images if I could. But yeah, these are traumatic hemorrhagic contusions secondary to trauma involving the frontal and the temporal lobe on the left side.
This is the midbrain. This is the midbrain. Are you happy with the midbrain, the shape of
No,
the
no. So there is basically herniation, uncal herniation of the left temporal lobe, compressing the midbrain, and there is a possibility of infarcts due to compression of the vessels in this area.
where, please?
So I don't know if you can see my mouse, but so we have I think we can see the pons, we can see the prepontine cistern just about, and just the cisternal spaces around it completely are obliterated due to the mass effect. So any vessels or any nerves in that particular area could be compressed as well as a result.
Please remember that in transtentorial herniation, what happens is that the PCA can be compressed. When the PCA will be compressed, there will be a occipital lobe infarction. You don't see the occipital lobe very well in this case. Maybe partly you are visible here. So otherwise, there is no concept of any infarct in this territory. There can be small, you won't see them in CT. So the point is that PCA is the main thing. Now, what is happening? Of course, you are handicapped because I have not given you all sequences. But the idea here was you picked up very well these findings of subdural. There was a subdural. Of course, it's absolutely legitimate to ask for reformats when you pick that up. And there is a lot of edema. And that is why there is herniation, and maybe there is bilateral herniation, early bilateral, what we call central herniation. We'll come back to this. The point what I'm making in this case, it's a simple case. So you will immediately pick it up that there are contusions, but keep looking for more findings. As you have picked up subdural, then you picked up transtentorial herniation. Keep looking for any further complication as infarct, etc. So that's fine. Well done. Expanding contusion. So if you see here, subtle cases which you will get in the exam will be in which there will be subfrontal contusion, and subfrontal region is usually, you don't see it very well because of artifacts, right? And this kind of finding here. So beware about that. Having said that, this case is expanding contusion. So look here, and then what has happened after 12 hours. Huge. So, and then there is intraventricular hemorrhage also. Point is that if the patient deteriorates, don't be a hindrance in telling them that I don't want to rescan, just rescan and you might find something. So busy scan, over to you. Trauma, of course.
So these are again multiple axial CT head, plain CT head slices. You can, starting from the top left-hand picture, I can, just looking at the sinuses, I can see that there is high attenuation within the sinuses, the sphenoid and the ethmoid air cells. There's also high density, spotty high density seen within both temporal lobes. And you can see along the right temporal lobe, you can, or the middle cranial fossa, there are small pockets of air. In fact, they extend along the right convexity, representing pneumocephalus. So, and there's also in the lower slices, you can see that there is subarachnoid and a subdural collection. So my suspicion over here is the patient has had a right-sided injury with a fracture with associated pneumocephalus and a coup injury, resulting in hemorrhagic contusions, subdural and subarachnoid hemorrhage with a counter-coup injury on the opposite side of the temporal lobe. And the gray-white matter differentiation is very poor on this particular CT. So I'm also concerned about hypoxic brain injury in this case.
Yeah, just so you've done very well. I wanted you to comment on the sulci. Do you see any CSF spaces?
No, the sulci are completely obliterated due to significant edema.
And so with that, there is loss of gray-white matter differentiation, right? And means trouble, means there is no blood supply coming. And this is, do you see that if you look at the cerebellum here, look at the density, it is more than here. So what do you call this sign?
I don't know the name of the sign, but yes, in the hypoxic brain injury, this is one of the things we look for. There's a dense cerebellar sign. I think that might be it.
Hyperdense, yeah, white cerebellar sign, right? White. We call it white cerebellar sign. So now this is these kinds of cases have come so often in the exam. Here, the findings are very obvious, but you have to pick up everything, and then the examiner is going to ask questions. It will be discussion. What is happening? Why is it happening? And if you see here, loss of complete effacement of CSF spaces was a critical finding here. You don't see anything, any basal cistern, any cell site. Complete loss of gray-white matter differentiation means there is ischemia, and maybe there is a bit of blood coming in the posterior circulation, and that's why cerebellum is still white, as in viable. The rest of the findings you picked up very well, and of course you have to tell the examiner that I would like to see the bone window. It is his choice if he or she wants to show it to you or not, but that should be critical. Now, here we come into this word, secondary effects. And secondary effects have been asked in the exam so many times. Please remember the concept. The concept is that the skull is a closed space. And there are three things in this closed space. Intracranial blood. This blood is within the vessels. May they be arteries or veins. And then CSF, and then the brain tissue. Brain tissue is usually, as we know that all of us, brain tissue is mainly water, right? So all of these three things have to be in equilibrium. What happens is, if there is diffuse brain edema, something has to decrease. Now, CSF is a liquid, and principle of physics is that you cannot compress it. So what happens? The vessels get compressed, and that is why you get ischemia. And this is what we call the Monro-Kelly hypothesis, and this is asked in the examination. And ischemia and the head injury, this we have covered in the past. This is totally different. So here, ischemia and the head injury, an increase in brain tissue leads to compression of vascular causing ischemia. This concept is asked in the exam. Spontaneous intracranial hypotension we have covered in the past, and that's a totally different entity, but the same hypothesis will work. So the point is that if you get a busy type of scan in the examination, do not stop. Keep looking for things, keep looking for things, and see, this is a more or less a dead brain, right? So that is the importance. Candidate one, this patient, again, A&E, trauma.
So these are multiple axial plane CT head slices. And I can see that in the inferior aspect, starting from the top left, I can see in the frontal lobes bilaterally, there are small areas of high density with minimal surrounding low attenuation. Coming further down into the lower set, I can see a more prominent focus area of increased density in the right frontal lobe. The sulcal spaces are still observed, are not completely obliterated, especially when we go up towards the vertex. But overall, these are small areas of hemorrhage with minimal surrounding edema in the subcortical or the corticomedullary junction. And given the history of trauma, suspicion of diffuse axonal injury is raised. There is no evidence of hydrocephalus on these slices and no significant midline shift or significant mass effect associated with these.
Okay, good. So another case, over to you.
So these are, again, plain axial CT slices, and over here there's over exposure of the bones. The brain parenchyma itself, starting from the top left, I can see that the cisterns are clear. There's no obvious high density to suggest any hemorrhage within. Looking at the other slices, I can see small foci of high intensity in the right thalamic region, and also at the splenium of the corpus callosum in the left lower image, and further up, going up towards the right lateral ventricle, just adjacent to that, and in the right frontal lobe in the bottom right hand image. So we've got multiple areas of small hemorrhagic foci seen in the thalamus and in the corpus callosum and in the right frontal lobe. And this is in the this isn't at the great white matter junction or anything, but these are in the context of trauma are highly suspicious for small hemorrhagic foci secondary to that. There's no hydrocephalus on these axial slices that I can appreciate, and the great white matter differentiation is maintained. I would like to have a reformat the images and have to look at the whole scan.
So the point is that pathologically speaking, what is happening here or here? So you use the word gray white matter. You said that these are not at the gray white matter differentiation. So let me ask you a question. At which places can you see diffuse axonal injury?
It should be at the gray white matter differentiation. I would take back what I said.
You mean to say gray white matter junction, right?
Yes. I take back what I say. I think no, this is at the gray white matter junction. Concentrated on the bottom right hand image for some reason, but yes, all of these other places are at the area of gray white matter junctions.
Okay, so let's revisit diffuse axonal injury. What is diffuse axonal injury? As the name tells you, it is injury to the axons where in the cerebral hemispheres, and in the cerebral hemisphere, usually it is deep white matter and gray white matter junction. Then it can happen in the corpus callosum. Then it can happen in the brain stem. Then it might happen in the cerebellum. But having said that, it can happen in the deep gray matter also. I'll come back to this point. Basically, what happens is that diffuse axonal injury is a shearing injury. And what you see on imaging is microbleeds. Microbleeds are actually a consequence of damage to the vessels. And this is an indirect marker of diffuse axonal injury. Usually, these patients will have a sort of a not very bad looking CT scan, but clinically, they will be, they might have Glasgow coma 5, 7, they will be bad. And please also remember that if there is a concept of hemorrhagic diffuse axonal injury and non-hemorrhagic. You might get a completely normal scan because CT scan might not pick it up because there is no hemorrhage. So if you're a neurosurgeon and you get a road traffic accident with a normal CT with a Glasgow coma 4, you just label it, it is diffuse axonal injury. You presume that this is diffuse axonal injury. Now, the concept, hemorrhagic or non-hemorrhagic, 80% are non-hemorrhagic. So we won't see it. And usually we will see associated traumatic subarachnoid hemorrhage or intraventricular hemorrhage. Now this location is important. There can be too many things which can be involved. Classically, we all, teach that it is at gray white matter junction, it is in corpus callosum, it is posterior limb of internal capsule and midbrain. Having said that, there are so many other things which can be involved. And deeper brain involved means increasing severity. And this is a question which the examiner is going to ask you. So for example, here what is happening? Here, in this case, gray white matter junction is usually involved, these are versus this case in which the thalamus is also involved. Splenium is also involved. Here the prognosis will be worse off. If the midbrain is involved, it will be absolutely, even worse. Now, non-enhanced CT can be normal between 50 and 80%. All of these things you have to remember because in the exam, they have shown diffuse axonal injury on MR. MR will show you on a T2 weighted or a flare sequence, there will be high signal. T2 star or SWI will show you hemorrhagic foci, microhemorrhage, which might not be even visible on CT because the sensitivity is much more. And please remember, SWI is more sensitive than T2 star. And it might show restricted diffusion. You have to remember it, otherwise you will be confused. What is the pathology or the pathophysiology? Basically, when the tissues are of different densities and there is sudden deceleration, then there is abrupt changes in angular momentum and the axons are stretched. So sometimes they can be completely torn or shear. And so that is the mechanism of action. Please also remember that sometimes it can happen with low energy trauma. Of course, it can be with high energy trauma as in road traffic accidents, etc. But a patient might, in their home, they might fall down from what we call the ground level fall and can have diffuse axonal injury. This is the principle. Always consider diffuse axonal injury if the Glasgow coma scale is low. And there are various minimal findings on non-enhanced CT. You can consider doing a MR, not in an acute sense. So nobody does an MR on the same day and things like that. But at times MR is done to see what has happened, to see the prognosis, etc. So these are various sites. The red ones are most common site, red ones. So these are gray white matter junction, right? Look at the splenium. The splenium is red, but green sites are less common. So the body here or the anterior portion can of the corpus callosum, and then you see the posterior limb of internal capsule, the basal ganglia, etc. They can be involved. And in the midbrain, the posterior surface is particularly involved. This purple thing, you know, if you get it in the pons or in the midbrain, it is the most severe type of diffuse axonal injury. So this is a pathological specimen, and of course, it will be associated with many other findings. Look here, so many sites are involved, and there is intraventricular hemorrhage, subarachnoid hemorrhage, etc. This one is the worst possible, where you have got midbrain diffuse axonal injury, a bit of traumatic subarachnoid hemorrhage in the interpendicular system. So if you get this case in the examination, the examiner will give you, you know, I'll keep half a mark if you pick this up, and if you miss it, then I will penalize you half a mark for this. This is on a FLAIR sequence. This patient had no findings. Correction on a CT scan had no findings. The Glasgow Coma scale was low, and on a FLAIR sequence, you can see these high signal intensity foci. This is diffuse, but the best sequence is, and in the exam also, you will say that I want to do a SWI sequence or a T2 star. This is case 1, T2 star. You see these micro hemorrhages, and this is SWI, and you see these micro hemorrhages. In your book, micro hemorrhages on MR, acute trauma, hemorrhagic shear injury is number 1 in the list, and these are other conditions. And also another differential in your Chapman is about trauma, and these are the top sites: diffuse axonal located at gray white matter junction, corpus callosum, and brain stem. But please remember that other sites can also be involved, and the deeper the site, the worse the prognosis. Okay, candidate 1, thank you very much. Candidate 2, are you with us? Candidate 2? Candidate 1, can you hear me?
Yes, Dr. Khan, we can hear you well.
So now, who is speaking? This is candidate 2 who is speaking?
No, I'm 3. I'm not 2.
You are number 3?
3, yeah.
So I am calling candidate 2. Candidate 2, I can see you. I have clicked on ask to unmute. Are you there? No? Maybe candidate 3, are you happy to take over, right?
It's fine. It's up to you, sir.
So just to confirm, you are candidate 3, correct?
Yeah, I'm candidate 3. You just asked me if I can hear you well, so I can hear you well.
Okay, so you know, this is diffuse axonal injury, and just for the purpose of practice, I just want you to take us through the findings on these sequences. We know the diagnosis. Please, over to you.
Okay, thank you. This is MRI of the brain, multiple sequences, axial cuts. I can see there is multiple area of intraaxial.
Okay, just 1 second, please. What is this sequence?
This is flare,
This one?
susceptibility, SWI.
Yeah, very good. So this is, and this is SWI, and this is?
This is diffusion, sagittal and axial. This T2.
Okay, very good. So please continue with your description.
I can see in the flare axial, there's multiple intraaxial area of high flare signal intensity seen in the subcortical white matter, bilateral frontal, as well as left parietal region. On the T2 image, I can see also similar signal intensity seen in the basal ganglia, likely the right thalamus or right posterior limb of internal capsule, also on the left peritrigonal region. On the susceptibility weighted images, they are all showing dark signal, which is blooming, denoting the underlying homologic component there. On the diffusion, I can see there's marked diffusion restriction of the geno as well as the splenium of corpus callosum. However, my routine practice, I usually correlate with the ADC to confirm this as low signal intensity on ADC. So in a summary, this is a case of multiple hemorrhagic area and the white matter, subcortical white matter, bilateral frontal, as well as right basal ganglionic region, the corpus callosum with some diffusion restriction and the blooming artifact. These all are features of diffuse axonal injury of history of high traffic accident is given.
Okay, thank you. So, well done. Now, the learning point here is that if you see this flare, though I've just given you one sequence, in the examination, this is what is going to happen. The examiner is going to open an axial slice, and you have to develop your eyes to pick up corpus callosum abnormalities, which is a favorite. And in this, you can imagine that the corpus callosum is abnormal and on this flare. And of course, it shows restricted. Another learning point is that diffuse axonal injury can show restricted diffusion, and of course, deep gray matter, etc., can also be involved. That's fine. Now, look at this case, and in this case, this is a classical viva case, though I'm showing you just as a teaching case, where if you see there is a bit of edema, generalized edema, and the only finding, if you look carefully, is this thing, high density. And so this is what I say, that you have to develop your eyes to pick up findings in the corpus callosum. The same patient was scanned day 2, and again, there is a bit of high density here, which is a diffuse axonal. The site tells you that there is a diffuse axonal injury. This one has got multiple diffuse axonal injuries. If you see here, gray white matter junction, and then posterior portion of the midbrain, classical. This will be the worst prognosis. So I think because you have already done a practice in a similar case, I'll just describe it, and we'll also save some time. It is similar to the case which you saw previously, but if you see here, this is a T2 flare. This is a T2 star and DWI. This patient is 24-year-old motorcycle accident, Glasgow coma 5, CT was normal. And if you see carefully, then on the flare, look here, there is a bit of high signal, and there is a bit of high signal here. And here in the white matter, a lot of high signal, which corresponds with restricted diffusion at the splenium. You see this thing has got restricted diffusion. and up here also. And similarly, on the DWI sequence, though we have not seen midbrain in other sequences, you can see restricted diffusion. And this lesion in the thalamus, which is this one, shows blooming artifact. So similar findings to the first case, nothing new, but this is diffuse axonal injury. Okay, candidate 3, please describe this case.
Okay, this is the selected images of axial CT brain with no history given. I can see there's a bilenticular.
There is history of trauma. There is history of trauma.
With a history of trauma, I can see there's a left-sided extraaxial bilenticular high density area, which is keeping with extradural hemorrhage on the left side. On the right side, I can see a small hemorrhagic area, cortical location, in the right parietal region. And I can see also some fresh blood density seen in the right subarachnoid space. I'm checking now for any other hemorrhages. On this images, I can see intraventricular hemorrhage. So in summary, this is a left extradural hemorrhage with right subarachnoid and right brain contusion. These are causing a marked mass effect on the left side in the form of compression of the sulci and the gyri. However, I can't appreciate midline shift. In my routine practice, I would assess this carefully in the bone window to assess any fractures underlying. I can see also left subgaleal hematoma outside the skull bone. This is emergency. I would pick up the phone and call the neurosurgeon to inform him about the finding and possible decompression of this extradural hematoma due to compression of the ipsilateral sulci and cerebrum.
Okay, well done. So, epidural hematomas or extradural hematoma is a coup injury, and it will be extremely difficult. Just consider it as a coup injury. And on the other hand, this coup injury means the impact is here. There is a counter coup injury on the other side where you see a contusion and you see traumatic subarachnoid hemorrhage. You did well where you described a subgaleal hematoma, and you did well where you asked for the bone window. So basically, extradural hematoma is a collection between skull and dura, and 95% are unilateral, supratentorial. They do not cross the suture, but they can cross the suture. When they can cross the suture, if they are in what we call venous etiology. So please remember that extradural hematomas can be of two etiologies. One is arterial, which is middle meningeal artery, most commonly. However, they can be venous in origin. And this is what they will ask in the exam, venous origin. So we'll come back to this in more detail in the subsequent slides. So when there is venous extradural hematoma, it can cross the suture. On the other hand, when there is suture diastasis or a big fracture, again, it can cross it. This sign is important. This sign is asked in the examination, Sewell sign, where I'll show you, where what happens is that the concept is that there is acute hemorrhage as the patient is indirectly bleeding. So on the table, on the scanner, and there will be low density within the high density hemorrhage. And so these concepts are also asked in the exam. And mostly 90 to 95% will have a fracture involved. So this is the concept which you have to remember. Arterial is 90 to 95%, venous is 5 to 10%. And the locations, you have to really remember them. You know, other than the dural sinuses, for example, the transverse sinus, etc. Do not forget vertex, the superior sagittal sinus. And anterior middle cranial fossa is very important to remember. I'll come back to this point. Clinically speaking, there is a lucid interval in 50% of cases. The patient might be well and then deteriorates rapidly. Small subdural, extradural hematomas may be managed non-operatively. So this is it. You see this? It shows you that Sewell sign, active bleeding is happening. And this is what is very important in the exam. This is an extradural hematoma. This is another patient extradural hematoma. Within that, there are low density foci, and the examiner is going to ask, what is it? And the concept is that there is active bleed. What will you do? And I'll pick up the phone and tell the neurosurgeon that there is active bleed going on. This patient is going to deteriorate very, very rapidly within minutes. So it's a real emergency. Take the patient immediately to the theater. That is the message. It's a telephone thing which they are expecting you to say in the exam. Again, I told you that there is a concept of expanding extradural hematomas. So this is 2 o'clock and 4 o'clock, and this hematoma becomes a large hematoma within 2 hours. So key point is that if clinically the patient has deteriorated, don't be a hindrance in rescanning the patient. Yes, please. Candidate 3, over to you. This is after this case, we will take a break. Over to you.
Okay, thank you. This is CT brain, axial cuts, soft tissue, and bone window. I can see there is an area of blood density seen on the left occipital region, giving bilenticular shape, which is extradural hematoma. I can see high density along the tentorium, more on the right side, suggesting underlying hemorrhage. I'm checking for any other intraparenchymal or subdural hemorrhage, which is not obviously seen. However, in my routine practice, I usually assess this in subdural hemorrhage window. No intraventricular hemorrhage. I'm checking now for the bone window for any fracture lines. I can see the left occipital bone is slightly deformed. However, I can't see definite fracture lines seen there. I can see there is some gas density seen on the left jugular foramen or jugular bulb location. I would assess this carefully on the workstation to see if this is gas. This might indicate
this was gas. This was gas.
This was a gas. So this denoting underlying fracture of the base of skull or petrous. I can see some fluid level in the sphenoid sinus. In context of trauma, this might be a hemorrhage into the sphenoid sinus. So in a summary, this case of trauma with left extradural hemorrhage, right tentorial hemorrhage too, with the fracture on the base of skull, with the gas on the left jugular foramen and fluid level on the sphenoid. I can see there's minimal compression mass effect on the left cerebellum. I would pick up the phone and inform the neurosurgery about this, with also a left subgaleal hematoma. So I forgot to mention this.
So how can you explain this gas?
This might be a fracture on the mastoid air cells or middle ear cavity. So this spread to the left jugular. This is the possible explanation in context of trauma.
So you mean to, do you see a fracture here, by the way? There's no fracture.
On the, yeah, I can see fracture lines actually on this images. But this gas is warning, especially in trauma. It's
Right.
concerned.
Okay, that's fine. So you did very well, except for you could not decipher the gas part of it. This gas is within the jugular vein. Now, go back to your anatomy. What has happened? This is the transverse sinus here. There is a fracture. What has happened? That fracture has ruptured the transverse sinus, and that is why there is a venous extradural hematoma. This is a classical example of a venous extradural hematoma. And you can imagine that gas, just like pneumocephalus, has gone into the transverse sinus, which has then gone into the jugular vein. Please remember, pneumocephalus can happen in various compartments in trauma cases. Gas can be within extradural space, subdural space, within the vessels, within the parenchyma. And I think later in this session, I'll show you a few examples. But this is an extremely good 2B case, this one, which checks your concepts and which gives you all kinds of findings. So this is a venous extradural hematoma. You did very well where you picked up a subdural also there. So what is the bottom line? Bottom line is that in 10% of cases, the extradural hematoma is a venous extradural hematoma. And this is a good example which shows you. So we stop here. You will continue for another about one or two cases, candidate 3, and we will see if candidate 2 is with us. We'll give him or her a chance. And if candidate 2 is not with us, then we will go to candidate 4. But the next case is still yours. So 5-minute break now. I'll open the chat and we'll come back after 5 minutes.